Aleksandra Rachitskaya. I'm from Cole Eye Institute, Cleveland Clinic, and I'm excited to invite you to today's new Retina Radio Journal Club that is done together with Bitbuckle Society. I have a pleasure of being joined by my three colleagues. We have Dmitra Skondra from University of Chicago in Chicago. Dmitra, how are you today?
I'm good. Hi, everybody.
Awesome. And we have Mike Klufas from Wills Eye Hospital and Mid-Atlantic Retina in Philadelphia. Mike, how are you doing?
Good. How are you? Thanks for having me.
Excellent. We're excited to have both of you. And we have Emmanuel Chang from Retina and Vitreous of Texas in Houston. Manny, welcome.
Hey, thanks for having me.
So what we're going to do today, we're going to talk about two studies, and we're going to summarize the studies for you and then have a discussion on these studies. So the first study that we're going to talk about is C5 inhibitor, avacincaptad pegol, for geographic atrophy due to age-related macular degeneration. This is the GATHER1 trial that was published by Glenn Jaffe and colleagues, and it came up in April 21 issue of Ophthalmology. And second study that we're going to cover is characterizing new onset exudation in randomized phase 2 FILLY trial of complement inhibitor pegcetacoplan for geographic atrophy. And this is a publication first authored by Dr. Charlie Wyckoff, and it came out in the March issue, March 2021 in Ophthalmology. So let's start with a summary of these papers, and we'll start with the GATHER1 trial, and I'll ask Dmitra if you can summarize that for us.
Okay, thank you, Aleksandra. Thanks for the invitation. It's great honor to be part of this great group for this discussion. So GATHER1 is the purpose of the study was actually to identify the safety and efficacy of avacincaptad pegol. We'll call it Zimura for interest of time going forward and convenience for geographic atrophy secondary to age-related macular degeneration. Zimura targets C5, which is one of the downstream factors in the complement cascade. And this was an international prospective randomized double-masked sham-controlled pivotal phase 2 and 3 clinical trial. It had a total of 286 patients, and the primary outcome was basically to see if Zimura decreases the mean rate of change in geographic atrophy over 12 months, mostly on autofluorescence, and the time points were baseline 6 months and 12 months with monthly injections. So the results were that there was a reduction in the mean rate of geographic atrophy, and that was calculated by the square root transformation. And at month 12, both the 2 milligram dose and the 4 milligram dose of Zimura decreased the rate of geographic atrophy about 28% in both groups. And they were both statistically significant compared to the sham group. And in general, they were well tolerated. There were not any ocular or systemic adverse events. In conclusion, the study said that the drug is safe and effective. And actually, a second pivotal trial got approved and enrolled, which is going to be the GATHER2. An important point I think is to make that even though there was no ocular severe adverse effects and systemic, there was an increase of the rate of exudative neovascular AMD patients, about 9% in the Zimura group, and these eyes were not included in the analysis of the geographic treatment because there was concerns would affect the measurements of geographic atrophy.
Well, Dmitra, that's an excellent summary of this paper. Very exciting results, and I think all of us in the world of retina are excited that we might have something finally for these patients. So, Mike, let me ask you a question on this study. What do you think is, looking at the inclusion-exclusion criteria in this trial, and they didn't include patients who had, for instance, neovascular AMD in the other eye, or patients who had GA involving the fovea. How do you think it applies to your geographic atrophy patients that you see day-to-day in clinic?
Yeah, it's a good question. And the follow-up trial that's going on, for instance, I had a great patient who had non-subfoveal GA, but when she got into the room for ETDRS vision, she was actually 20/20, and you're excluded from the most recent trial if you're not 20/25 or worse. So I think the bottom line will be this will likely be a first-in-class agent as long as it's approved and it meets an unmet clinical need. But the clinical indications we use it for, unless the label is very restrictive, may be a little bit different than what's used in the actual clinical trial.
And I think it's it's always important to see right what the indications are going to be, because the geographic atrophy patients that we see, they're so diverse. Somebody might have a little bit of a GA, or somebody might have this huge geographic atrophy, multifocal, unifocal, all kind of patterns of autofluorescence. So it's going to be interesting to see how these trials are going to apply to these patient populations. The other question that comes up, and Manny, maybe I'll ask you, is what do you think about the treatment regimen? How do you think it's going to be adopted by providers and by patients?
I think that's a great question. Obviously, even now with anti-VEGF injections for wet macular degeneration, the treatment burden is quite high. You get treatment fatigue, and the challenge would be for many of these patients, especially if in wet macular degeneration, when patients even see an initial improvement when they get treated, now you have a disease entity that we know is progressive with time with GA, but patients don't appreciate a difference in their vision. To ask them to come in regularly for treatment, there's going to be a lot of counseling, a lot of showing images to try to educate patients the importance of staying with treatments over the course of time.
Yeah, I think, and we'll touch a little bit about it as we discuss both of these publications. It is something that's important, and I think one of the webinars I was attending, somebody mentioned, we're going to be a little bit like glaucoma doctors. The patient doesn't perceive a problem, and you're like, well, you need treatment. So let's move to this post hoc analysis of the FILLY trial, because Dmitra touched upon it in the GATHER1 trial, and this is this concept of conversion to exudation. So Manny, do you want to walk us through this trial and the results?
Sure, thanks for having me. So the FILLY trial was published earlier this year. When it came about because many of the study investigators noted in the FILLY trial that they saw, or they felt like they saw, a higher instance of wet conversion in eyes that were treated. And so in this paper publication, it's a post hoc analysis of that phase 2 data, looking at pegcetacoplan, the APL2 in geographic atrophy. They followed these patients and treated them for a year. There were, in the trial phase 2, there were monthly injections and every other month injections during the year. And then afterwards they stopped and they followed them out for 6 months. They were looking at specifically at the rate of conversion in patients who got treatment with the complement, the C3 complement inhibitor. They noted that it definitely worked in the FILLY trial, that it reduced geographic atrophy, but they also did identify that a sizable percentage started showing signs of wet macular degeneration after treatment. They didn't see a temporal association, but it definitely was significantly increased, as well as if the fellow eye had a history of wet macular degeneration, they also noticed a higher rate of conversion in these patients.
So I think these are some of the interesting post hoc analyses, and of course they have limitations, right? These were conversions that were identified by investigators, and I think there wasn't as rigorous maybe analysis of what happened once these patients were deemed to have converted to neovascular AMD. Even in the paper, it mentions that not all of them got a phase, and just because it wasn't mandated as per protocol. So Dmitra, one of the things that's mentioned in the study is attention to OCT finding of double layer sign. And there's been a lot of discussion of double layer sign, I feel, in the last couple plus years. So what is your take on it? Do you look for it in clinic? Do you do anything when you find it? What's your approach?
So I look at the OCTs not for their lack of or no exudation. Obviously, that's the first thing we look for someone with his dry macular degeneration, if they have intraretinal fluid, subretinal fluid, and hemorrhage on exam. But I always look very suspiciously on this like low line PDs, which is what this double layer sign represents. And I think that for me, OCT and geography has really helped these cases to identify these like non-exudative occult membranes that they have not converted to exudative phase first. So I think it makes a lot of sense, that fact that when they look back and saw the eyes that developed exudative AMD, actually many of these eyes did have this underlying low-lying PEDs. They may be harboring some non-exudative or the beginning of membranes. So I think looking at the OCT and possibly including OCT angiography, especially swept source, because those are type 1 membranes that sometimes the regular non-swept source OCT angiography can be hard to kind of like reveal the membrane. I think it's going to be a very important component, not only for the next trials, but also when we bring this to clinical practice, now that we know this is a risk factor.
Yeah, I think it was mentioned in the discussion that OCTA was not part of the trial, and it would be very curious to see exactly what OCTA looked on in these patients. And I'm gonna ask Mike. You know, we are talking about these GA patients, right? We used to probably just get OCTs on them, maybe some autofluorescence, and now we are running into, you know, there's different ways to look at GA to begin with. Most of these trials that we're discussing today are looking at autofluorescence, but there is a lot of other studies looking at other ways to look at these patients. We are looking now, should we be doing FAs on them and OCTAs, as Dmitra mentioned? How do you see this imaging kind of aspect of GA management being incorporated in your practice, whether or not these drugs get approved?
Yeah, it's a good question. One thing that's always dawned upon me is, especially if there's a family member in the room and it's unclear what the cause of vision loss is and there's possibly GA, even if you show them an OCT, it's very difficult for the lay eye to see geographic atrophy, or even if we see it on the IR, but showing the patient or the family member fundus autofluorescence and that blackness and equating that to cell death is a very easy analogy for patients and families to understand and potentially initiate a discussion for a clinical trial or a potential treatment that may be available in the future. You know, in some of the sister studies for Zimura and Stargardt's disease, they're looking at NFOS OCTs of the outer retina to further quantify these types of changes, complement inhibition. So I think we have to see, but probably fundus autofluorescence is the most accessible and easiest non-invasive test we have right now, especially in some of these patients who aren't great fixators.
And I'd like just to make a comment on that, add to what Mike said. This kind of like more of advanced imaging techniques, it depends a lot of the manipulation, doing custom segmentations, where you put the slab of the outer segment, especially with OCT angiography, geographic atrophy, it's very tricky to interpret. I have many patients that come to me that they've been treated for wet AMD because someone did an OCT angiography and saw vessels. It was actually a segmentation default, and it looked like vessel actually was the corner capillary. So it's important, these image modalities, but in non-experienced hands, it can use a lot of artifacts, and it's not as good reproducible as a fundus autofluorescence thing. So we need to be careful when we set a plan is more advanced, that the practitioners really feel comfortable interpreting these images.
Excellent point. So we are going to take a little break, and we're going to come back for more in-depth discussion of this manuscripts. And thank you guys for excellent comments so far. Welcome everybody back to the new Retina Radio Journal Club, done with in conjunction with Buccal Society. And I'm Aleksandra Rachitskaya. I'm joined by Dmitra Skondra, Emmanuel Chang, and Michael Klufas. And we're talking today about geographic atrophy and some of the promising drugs. We have some early trials. None of these yet have all the final results, but some very exciting information on the growth of GA. And we talked about the GATHER1 trial and also about FILLY trial. We also touched upon the fact that in both of these trials, we saw that the patients who were treated with the study drugs ended up converting to neovascular AMD at a higher rate than the patients who were treated with sham. And of course, it's hard to compare these particular trials because the patients who were included are slightly different, the treatment interval is slightly different. So, but we do see that there is a signal there. So I'm going to ask the first tough question to Manny, and nobody really knows, but there's some theories out there why we might be seeing this increased neovascular AMD conversion. Manny, do you want to comment on that?
So thanks for asking me the question. The interesting thing about the post hoc analysis was, even though they didn't see a temporal association, they did find a dose dependent. The patients who were injected monthly compared to every month had a higher frequency of neovascular conversion. They also identified those patients who had this double layer sign, or the fellow eye became or developed had wet macular degeneration, which were excluded in the Zimura trial, but in the FILLY, they analyzed that. And those patients had a higher instance of conversion. There's been data that's come about. We know complement factor mutation, the H mutation, the cascade is important. People who carry these mutations have a higher complement activation in their systemic system, and that then forms a membrane attack complexes, which damages the RP and atrophy. But the complement system is also important not only for innate immunity and fighting off infections, but also in inflammation, also for clearance mechanism to clear the debris. And we know the RP is highly, highly active to clear out photoreceptor processing. And so the curious part would be is whether or not, if we are suppressing complement activation and suppressing the body's clearance of kind of waste product buildup and debris, whether or not that is triggering or promoting eyes that have this predisposition for wet macular degeneration to develop a neovascular membrane. And that may be why we see these double layer sign patients are more predisposed, or fellow eye having a history of wet AMD. There may be an underlying kind of complement dysregulation that predisposes them to wanting to form a neovascular membrane.
Yeah, it's fascinating. And I think as we learn more and more, and we have more definitive data, as we talked early in the segment, these patients maybe weren't analyzed as we would want them completely, with some of the other imaging modalities, we might have even more information. Dmitra, if you, let's imagine, these drugs, or one of these drugs, or both of these drugs are approved. How do you see this fitting into your practice with this aspect of neovascular AMD? What are your thoughts on that problem that we're seeing?
As was pointed out in discussions in both, especially in the FILLY paper, I think it's a concern, and definitely would like to see more data out to see how the outcomes of these patients are. When in about having the discussion with the patients, I think it's important, if they have already wet AMD in the other eye, and the idea that they may have to have double treatments in the second eye, in addition to monthly treatments in the eye with AMD, it may be a hard sell. So I think it may be hard to recruit patients or persuade patients, telling them, there's like 10 or 20% chance you may develop wet AMD in this eye as well, and we need to continue treating you, in addition to continue treating you for your geographic atrophy. And the burden is a problem for these patients. I mean, they're already struggling to keep up with the schedule as it is. Another important thing is that at some point we will need to see what's the long-term outcomes and for the vision. And also there's some evidence now that sometimes these membranes that develop at the edge of the geographic atrophy may actually protective, and they need to slow down the progression of geographic atrophy from other studies that were actually published this year. So I think they still need to be learned before we finalize our guidelines for the clinic, besides the criteria from the FDA. And it will be interesting also to see genetic testing results to see if there's a difference between the genetic makeup of these patients that develop exudative AMD or they don't.
And maybe if we take a kind of a bigger even picture view, and maybe I'll ask you, Mike, thinking even without neovascular AMD component, but just GA, and these are the patients that we used to see, maybe every 6 months, maybe in some cases every year, and now we have a treatment. How do you think it's going to affect our day-to-day retina practices?
Yeah, Dmitra and others have brought up a good point about the genetic testing. And what I've been surprised clinically is, many of the patients in their 90s may have geographic atrophy, but if their other eye's okay, they may be reluctant to undergo therapy in their worst eye. But if you look at some of the younger patients who develop early onset GA, they likely have complement factor variants that predispose them. And these are much more active people who may be more apt to pursue treatment. So I'm interested in incorporating genetic testing into my practice. I'll give you an example. One patient, she says to me, she has GA in like her early 60s, and she says, I got genetic testing at some point, 23andMe. I said, well, I'm not sure what it is, but I'll call you back later. Let's consider a trial. And I call her back on the phone. I bet it's CFH and ARMS 2, and that's what they test for. She's like, oh, you're right. It was CFH. But she's like, I don't want to be in a trial unless it's a CFH treatment. And I think that's a really savvy and smart patient. And, we're going to be seeing more and more of that, whether we're testing on our own or involved in some of these trials that are using widespread genetic testing for geographic atrophy.
And Dmitra, how, we talked about the two trials, kind of obviously different approach, but both complement approach. How do you see this fitting into all the other approaches and kind of targets that we have for GA?
Well, I think that the verdict is still to be out, and we need to be open-minded to kind of even if one trial gets approved, to still be actively recruiting patients for other agents that may be even better or safer, or they may have better long-term effects. But just to make a point, I think the most motivated patients probably going to be the ones already lost vision from GA one eye, and then they experience what it feels like. And I think probably they will be the patients that will be more inclined to be recruited, either for trials or for actually starting the treatment, that they know what's coming and they're very motivated to make sure it doesn't happen in their good eye as well.
I think patients I've seen too who ask how much is it progressing visit to visit, who may not have vision loss, and if you can show them definite progression over a 1, 2, 3 year period, sort of like a glaucoma progression analysis, they may be more apt to pursue treatment. Whereas if they don't see it progressing, they say, well, why would I want an intervention if it's going so slowly?
And I think that you're hitting very, all of you guys are making very important comments, right? Because there's also a lot of studies focusing on progression, right? Who is that patient that if we don't intervene, if we do have treatment, that we might lose vision, whereas somebody who, is probably going to be stable for a number of years because, these treatments, or at least the two that we're talking about, they're frequent injections. These are not come every 6 months. And maybe Manny, I'll get you input. So as this is moving forward, are you gonna see patients on Saturdays to do more injections?
It's gonna be tough. I think thank God we have longer acting treatment agents for wet macular degeneration, because otherwise it's gonna be hard. My fingers are gonna get tired.
Well, I think you guys have made very poignant comments. Excellent discussion. I do want to see if anybody has any other thoughts before we wrap up.
The only thing I want to say is that let's not forget, until we have something definite about the importance of diet and Mediterranean diet to decreasing risk of geographic atrophy. And I think that overall we should spend a little more time also to educate our patients about that, based on the recent paper that came out with analysis from the RSO data, because right now that's all we have.
Excellent point, and maybe a topic for the next journal club. Absolutely. So thank you so much to Dmitra, Manny, and Mike for joining me. This was the new Retina Radio Journal Club together with Buckle Society. Thank you.